So next up is Michael Walsh from the Big Apple.
Good morning. I'd like to thank the organizers, the families, Dr. Malkin for having me. So today the topic that I'll be discussing is screening challenges at a time of evolving variant classification and standards. So just a quick, or not, sorry. Here we go. Just a quick genetics refresher. Humans have trillions of cells. Our DNA is in our cells, and our DNA is our software for programming, if you will, and TP53 is one of 20,000 genes that we have. So historically in cancer genetics, we've taken a very conservative, rigorous, stepwise approach for the recommendations that we have made. And as the field of cancer genetics is evolving and sequencing is becoming easier, we're in a position where the manner in which we do testing and the pre-test probability for testing that is being performed is not necessarily as high as it had been previously. And this is good and bad for a few reasons. So next-gen sequencing and high-throughput sequencing, the first example of a benefit to this for Li-Fraumeni syndrome was the hypodiploid ALL story. So while we were using next-generation sequencing and having hundreds of patients with hypodiploid ALL, which is a very rare subtype of leukemia, we were able to show that in the non-tumor compartment patients have a significant percentage of patients had p53 mutations, but this was very much dependent on the phenotypic data that was also simultaneously available. And if that phenotypic information had not been available, this story would still be to be told. So the field, as I said, is rapidly moving. In 2013, March, this has been mentioned quite a few times, the American College of Medical Genetics came out with a gene list. 2 years later, they described how the variants should be interpreted for return. So in some ways, the carriage got before the horse, but I think this, based on just the way the field was evolving, this really was a necessary step. So medical geneticists, cancer geneticists, and oncologists view the world very, very differently. It sounds odd, but they do. And the perspectives each comes with has brought to light a lot of issues in terms of how we should think about genetic testing, for everything from the psychosocial aspect to actionability to trying to figure things out in very, very rare circumstances. So while I don't think any of those subgroups of providers has an issue with the specific genes that were selected, because they're the usual suspects in terms of cancer genes that are on the list, I think that in terms of timing, there's certainly debate between medical geneticists and cancer oncologists in terms of when gene testing should be done. So if we look, what do we find? At St. Jude, we looked at the 1,000 genomes that had been sequenced germline, and we found that 8.5% of patients had pathogenic or likely pathogenic mutations, and that the most of these were TP53 mutations, with the point that there was an ascertainment bias in this study for adrenal cortical tumors as well as hypodiploid ALL. Simultaneously, and since other papers have been published showing that around 9.5 and 10% of patients have, pediatric patients have germline mutations. So this is particularly important in pediatrics in terms of the availability of this information as we get past the initial lines of therapy. The germline information does become particularly relevant now, even in the sense of therapeutics, as we're increasingly using certain drugs for patients that have DNA damaging genes. Not necessarily TP53, but some of the others, and this is based on some of the work I was hearing yesterday. There's a lot on the horizon for this information in the treatment sense, not just the preventative sense. So a couple of cases illustrating the growing pains of having all of this sequencing information. So this is a case of a woman that came to us who had testing done at an outside hospital. She was found to have both a p53 and a BRCA mutation. She was tested because of her sister. When she presented to us, she did not have disease. We commenced screening, and she was found to have breast cancer. So in this particular case, the BRCA mutation alone could account for her increased risk. But the p53 mutation was one that there is a significant body of literature for in terms of being pathogenic, and she just as well could have made the risk reductive surgery based on this information alone. So after a period of time, the p53 mutation was reclassified as a variant of uncertain significance. We had, while all this was going on, tested her daughter, and her daughter was also found to have the mutation. Based on our own review of the data and contextualizing it, we're following her, although this is a real pathogenic mutation, based on criteria that we have for calling something pathogenic. This is a case of a child that probably historically wouldn't have been tested, yet there being case reports in the literature of neuroblastoma being part of LFS. So the boy, the one boy came to myself and Jennifer Kennedy, who's a counselor that I work with, and the parents were told that lightning had struck twice. We sent multiplex testing. The boy was found to have a pathogenic p53 mutation. Question was, is this true and unrelated? We tested the parents, they were negative. What's the story going on here? So Jennifer, through heroic efforts, went and tracked down tissue from the brother who had died, and was found also to harbor the same p53 mutation. So we're in the process of further evaluating the parents as mosaics, but we've tested the two siblings, and one of them also harbors the p53 mutation who we're screening. So in both cases, it can't be overstated how forward-thinking Dr. Malkin and Dr. Finley were in developing this protocol, because it gives us something to do for patients, and with the addition of adding some additional neuroblastoma-specific testing things to look at, this is pretty much what we follow for all of our patients. And for all of these unique situations that arise, I don't hesitate to contact Dr. Malkin on the bat phone, so to speak, or email, or Josh. So solutions, we need to understand population frequencies now that we have all this data generating. We need to gather as detailed phenotypic, genotypic information as possible to contextualize certain situations. All of this data needs to be deposited in a well-curated central repository by champion groups so that the information can be availed, and there are multiple efforts on this front. And high-throughput functional testing models are necessary. What are we doing at Memorial? Through a collaboration with Penn, Dana-Farber, the Mayo Clinic, we have a study called PROMPT, which is really trying to engage patients and their families that have had testing done, and laboratories. So there are 37 laboratories contributing to this study. So what happens if a patient has germline testing done and they're issued a report, they may or may not have seen a genetic counselor depending on how the testing was done. And the laboratories on the back of the form have a link to PROMPT to go to, or we make a point in clinic to tell the families to go to that site, and they can enter the variant information, phenotypic information, upload pathology reports, and that's been the first phase. Currently, we have over 2,000 participants enrolled, and it's been remarkable in some of the insights we've gathered from this so far. The second phase is to gather samples for segregatory studies in the family. So these are the people I want to thank, and that's it.
You bought yourself some time for questions. That was only 8 minutes. Perfect. So where do you think what do you think is the most damaging? Perhaps classifying something as pathogenic too early and then having to bring it back down, or being a bit slow about classifying something that we all think looks pathogenic so that there's a delay in certainty in a family?
It goes both ways. The conversations I've been involved in have always... Sorry. I think it goes both ways. The conversations I've been involved with have always been to be conservative and call something a VUS rather than to prematurely call something likely pathogenic. But this is an illustration here where we have a case where a patient could have made a very significant decision and then been told that it wasn't a variant at all. And the other situation where we wait and there's time that goes by, there is potentially information an individual might not benefit from. So, case being, so if there's a child or an adult or someone with a Lynch syndrome gene, and something is classified as a variant of uncertain significance, we know that they're eligible for certain immunotherapy trials. And while one can say we should find things in the tumor, there are certain profiles that should also clue us off, we all know there are limitations to sequencing and heterogeneity and screw-ups. So I think we need to be conservative and take a stepwise approach, but there are these one-off situations.
It can work both ways.
Yeah.
Thank you.
Yeah.
Oh, quick, Jonathan?
I'm concerned with the label of variant of uncertain significance.
Yeah.
How many cases are required to be documented, and how does one gather this information in for a consensus to be made that a particular mutation is no longer a VUS, but in fact is the real McCoy?
So the quick answer is we don't know. I know it's not satisfying, but so just kind of looking historically at how these guidelines for variants have evolved. Sharon Plon in 2007 and 2008 was writing on on classification of variants, and the kind of the elements that we should be paying attention to in terms of functionality and segregation and how common something is hasn't changed at all, but yet, despite that paper and others being out there, that was related to somatic, but the same evidence is required on both fronts. In the survey that the American College of Medical Genetics did, when they surveyed all of the laboratories, nobody was speaking the same language, and until that paper in 2015, the VUS, that terminology itself, wasn't agreed upon it hadn't been agreed upon by many labs, or they were using VUS, or there were all kinds of classification schemas. So I think the way we're going to get to where we want to get is to use both the linkage studies for families to find out these highly penetrant segregating variants, through GWAS try to find out some of these low penetrant, moderate penetrant alleles, take that for what it's worth, and we're going to develop over time a more three-dimensional way we look at this. They're a real problem. I don't know if I'm answering your question, but right now the gold standard, I think that the cystic fibrosis has a nice model in terms of the rigor they use for calling something pathogenic or likely pathogenic. They also have the trypsinogen assay to substantiate what they're saying with what they come across. The Insight group is certainly a group that has dedicated considerable efforts to functionally showing and having proper evidence behind what they're saying. Enigma on the breast cancer front. And then the TP53 database is a tremendous resource. There's some more functional work that needs to be done.
You've got to get that stuff in that database. So
yeah.
From a pragmatic point of view, so 4 years ago, I had a little 10-month-old diagnosed with a choroplexus carcinoma, right. De novo mutation, no family history.
Right.
The mutation came back extremely unusual, P53, and was reported as unclear whether this is carcinogenic. By the way, that child was diagnosed simultaneously, not only with a choroplexus carcinoma, but an embryonal rhabdomyosarcoma and a mediastinal ganglion neuroblastoma. So yeah. I kind of think it's the real thing.
You've got enough there.
Right.
If you show the parents do not carry that mutation, ignore what the report says. But the evidence there is so overwhelming.
Absolutely.
That is a
do I have to get this in the literature for somebody then to sort of respond to that and recognize
it? It will certainly help, because that then is an evidence factor.
Yeah.
And so just in terms of how the field has moved, the job I got in New York I wouldn't have got if I had been living in New York trying to do it, because of the way the laws are. So the work that I did in another state, there's a lot of variability in the way these things are kind of.
Thank you.
Sorry, we're going to have to move on.